Good evening, everybody. Thank you for joining us for today's presentation. For those of you who I've not had the pleasure of meeting, my name is J.R. Springer, and I am the Director of Development for the UC Davis School of Medicine and the Center for Advancing Pain Relief. I'd like to welcome all of you and thank you for joining us for tonight's Pain Matters presentation. The Pain Matters series is hosted by the Center for Advancing Pain Relief Advisory Board, and we owe them and specifically the members of the Community Engagement Committee our thanks for providing the vision for this series. I'd also like to take a minute to welcome two other people you may see on your screen, Kate Lorenzen and Christy Chung, who are the team behind CAPER and are keeping Dr. Scott Fishman in line as he works through these projects and programs. Our presenter today is Dr. Scott Fishman, who's the Fullerton Endowed Chair in Pain Medicine and the Director of the Center for Advancing Pain Relief. Dr. Fishman's presentation today, The War on Pain, will focus on the nature of pain and its usefulness as an intrinsic alarm system. We're going to encourage all of you to feel free to use the question and answer feature in the Zoom to ask questions throughout the presentation. He's going to do his best to answer those as we go through, but we'll also have some time to address any questions at the end of the presentation. We anticipate we will use all of this scheduled hour and possibly a little additional time. We hope all of you can stick with us. The recording will also be recorded, so we'll send that out after the fact. It's now my pleasure to introduce Dr. Scott Fishman.
Good evening, everyone. It's really great to be able to do this, and I see that we have some familiar names of folks joining us today. A lot of people that we know, but a lot of people that we don't know. So I welcome you all. And tonight is an opportunity to talk about a subject that's near and dear to my heart and has been my life work, that of pain. But even in the hour we have, I won't be able to cover everything that I suspect you'd want to know about pain. It's an area that interests all of us at some point in our life. And it has a lot of interesting social, not just medical correlates. So I'm just going to try to address some of that, but I'm really open to watching your questions. And if you have them, I'll try to address them. I'm going to move through the information quickly so I don't use up all of our time and hopefully leave time for a good Q&A session where we could even have you unmic and have a discussion back and forth. I don't think we're that large of a group. So I'm going to go ahead and share my screen. Hopefully everyone can see this and proceed. You know, I mentioned that this is my life work, and I can't actually imagine a topic that you know, kind of touches everyone and speaks to really the heart of medicine, you know, why we go into medicine. When I went into medicine, I couldn't think of a better area to go into than to treat pain. But, you know, when I tell my colleagues I'm a pain specialist, they often offer me their condolences. And for many of them, they couldn't imagine a worse place to be working. And it just speaks to the dichotomy of the issue of pain, which is we all would like to not have any. But when you have it, you'd really want to have somebody that was interested in it and really knew a lot about it. And consumers are increasingly surprised, I find, to learn that we don't really teach pain management to our clinicians, to our doctors, nurses, pharmacists, psychologists, social workers, physical therapists, etc. Even though pain's the most common reason that a patient or a client is going to come to them. Pain is the most common reason why someone becomes disabled in America. So it's an incredibly important subject area that unfortunately we ignore. So with that, I thought that I would say that while we ignore it, we are completely a chemically coping society where if you just want to walk through your local drugstore, you'll find treatments for almost anything you can think of as a symptom. And usually multiple remedies. So again, it's surprising that medicine hasn't embraced this area as a primary focus, but there are many others who have, and those of you who have heard this talk before have seen the Zapper, one of my favorite products from the 1990s. This product sold more units to the consumer than any direct-to-the-consumer product in the country. It was $79, and you put it on your skin. I initially thought it would go in your car lighter, but you just put it on your skin, you press the red button, it zaps you, and your pain goes away. At this point, when we're together, I often ask, how many of you think this really works? And usually there aren't very many hands, but every now and then there's one or two. And those hands that go up are right, that it actually does affect pain. It takes pain away by the same theory that my Uncle Charlie would mention to me when I complain of a headache. He'd say, I'll kick you in the knee and your head won't hurt. And this is a physiological response to a noxious sensory input through distraction. So the brain can only attend to so many things at once, and it goes to the loudest signal. You may have known that if you've had pain. So the Zapper actually works, but it was taken off the market because it claimed to cure pain. But I don't want you to fret. I just saw this, that this is on Amazon. You could buy this tonight, and it's no longer $79, it's $16.99, free Prime one-day delivery. So we've made advances in the field. There are many, many other tools out there that you can buy direct. You know about acupuncture. It's the most time-tested therapy known to mankind, been around for over 5,000 years. We know it works, but we really don't understand why. And we don't know who it works on. I tell my patients that I could send them to 10 acupuncturists and they get 10 different treatments, but some of them get better and remarkably better with very little risk. So there are acupuncture products out there. There are tons of different things that you'll find. These are lotions that you can get from the rainforest. And I often like to say that if you're gonna make a remedy for the public that they're gonna embrace, it should be all natural. At very best, it should come from the rainforest. And I say that tongue in cheek because some of the most toxic substances known to mankind come from the rainforest. But there's a belief that if it's all natural and the rainforest gives the imprimatur of it being pure, that somehow it would be safe for us. And this helps us understand the thinking of consumers. And there are all sorts of products out there. I can't tell you that these are these work or they don't. Some of them do. I don't know that any of them are super potent, but this reminds me to say that we love patches. Americans love patches, and there's a whole industry of things that you can adhese to your skin. We like shining lights on things. These are actually light bulbs that are supposed to take your pain away, or these are actually more advanced light bulbs, and these are zappers or stimulators. We still use stimulators, and in fact, probably the idea of using stimulation to treat pain is probably the most advanced technological intervention that we do now, where we place stimulators into the spine and other parts of the body to actually fool the nervous system, to essentially trap the bandwidth of pain by substituting it or cramming it out with non-noxious stimuli. And I'll say more about that in a little bit. This is a product, Super Blue Stuff, that was also very, very popular in the 90s and was removed from the market. Jack McClung was, I think, sued for claiming that it cured pain. But I see that it's back. I just found this a few months ago, and it's basically emu oil. And I don't know if many of you know what emus are or actually know how you get the oil out of the emu. I'm not sure I want to know, but it's a topical emollient that's supposed to be very soothing. It's blue because emu eggs are blue. I'm not sure if the oil's actually blue, but again, it's lore that this will help your pain. Now, this is my favorite product that I've ever found. It's the Reflexology steering wheel cover. It was $16 back in the day. Now it's $7, and it makes you feel better all over. And I just want to admonish you that if you're feeling better all over, maybe you shouldn't be driving. And this is a report that says America is going to pot. And I just wanted to let you know that that is in fact true. We love marijuana. And this is a change over the last decade across America, maybe not a change in California over the last decade. When I came here 22 years ago from Boston, it didn't take long for my first patient to ask about marijuana for pain. And over those years, I think we've found that cannabinoids, or the drugs that are in marijuana, clearly do affect pain, can be pain relieving, and do a lot of other things, and actually have a relatively low risk profile, even though it's not a no risk profile, which many want you to think about. One of the risks we have with marijuana is that it's not legal, and so it's not pharmacologically produced. So when a patient tells me they're using it, I have no idea really what chemicals they're putting in their body. But there are many, many, many products out there, many more this year than there were last year. There are dispensaries everywhere. It's now legal in many states, not just for medicinal purposes, but for recreational purposes, which is how my generation used it in the day. And again, we could spend the hour talking about cannabis. We had a good talk from Dr. Copenhaver on cannabis several months ago. So I'm not gonna linger on this subject, but boy, there's a lot of cannabinoid products out there. Really, the heart of our discussion today is about pain, and from a social perspective, one has to really wonder, why is it that we're a country that uses more pain relievers than any country in the world, particularly opioids? And we have, obviously, now that we have an opioid crisis, and yet we have the highest percentage of our population in pain, higher than any country in the world. We use more pain relievers. Our outcomes are poorer. We have a real problem in America around this, and I wanted to speak to that. You'd have to be living under a rock to not recognize that we have a problem with opioids, but this is really the data that grabbed our attention around the year 2010. I don't know that we really saw it, although many of us were watching this happen, where if you look at the red line, that's opioid analgesics. The green line are benzodiazepines like Valium, Ativan, etc. Blue line is heroin, the yellow line is cocaine. And what you see is basically opioids broke away in terms of unintended overdose deaths around the year 2000, around the turn of the century. And all the others went up a little bit, but mostly stayed relatively flat. The opioids have definitely been the major leader in unintended death. And this speaks a little bit better to the precise issues. So what you see here is the purple line are prescribed opioids. The black line are synthetic opioids that are coming in from Asia and other markets, and very inexpensive and overwhelming our population. And the orange or yellow line there is heroin. And what we've seen are really three phases of the opioid crisis. We had an initial phase where prescription drugs were driving the unintended overdose death problem. And then in 2010, you see an uptick in heroin use started. And then the black line started to rise precipitously around 2014, 2015. And that line has continued to go up dramatically even to this day, whereas the commonly prescribed opioid line is coming down. So we've done a lot to mitigate that. You can kind of see here that prescription opioid prescribing is declining dramatically, and it's really back to pre-opioid epidemic levels now. And what you're seeing is that there are far fewer unintended overdose deaths from those prescriptions. We've had a lot of guidance, but from the government and government intervention here. But what's happened is that the opioid crisis has pushed us to limit what we do for pain patients, and in many cases, we're completely stopping people from pain drugs that they had been on for years, and they're going to the street or they're committing suicide. So in 2019, the FDA and the CDC had to come forward and actually change their recommendations to prescribers to make sure they understood that the guidelines for using opioids are always meant to use them with compassion and risk management, but not to abandon our patients. So really what happened in our country is we went from really one extreme of being overly liberal with opioids to another extreme to being overly resistant to using them for treating pain or treating pain itself. And we're just trying to find the middle. I would say our program has been in the middle from the beginning and continues there. But basically, we got into this problem through many different forces that created a perfect storm. If you look here, this is similar to the graph I showed you before. These are unintended overdose deaths. And you can see here in the year, around the year 2000, something happened, which is the Joint Commission, which is the agency, the federal agency that certifies all hospitals and clinics, required every clinical visit to have an assessment of pain and a score from 0 to 10. I don't know if many of you remember when that happened, but I'm sure you've experienced this, being asked about, what number is your pain? And doctors felt that if the score was more than 5, they needed to do something about it. Now, the Joint Commission did this, I think, out of an abundance of humanity, that I think they figured that if only clinicians knew about the pain, they would surely treat it. But it turns out that none of those clinicians were really trained. And for a lot of reasons that I'm going to talk about, the easiest thing to do was simply to give an opioid, largely because that's what was covered economically by insurance companies. So, the problem here is that as I mentioned, none of your clinicians have really gotten substantial comprehensive education on how to understand pain, how to assess it, how to treat it safely and effectively, and how context affects it. So you have to wonder why they don't even do a worse job. This is actually a survey in Canada which found that the only clinicians that had even a modicum of training were the veterinarians, and this magazine cover that says your dog can get better health care than you. We also had a surge of patient satisfaction surveys, and I'm sure you've all received these about your healthcare visits now. This is a cover story from Forbes in 2013 that talks about a South Carolina emergency room doctor who had the worst patient satisfaction scores in his health system, and he then reversed them to make them the highest patient satisfaction scores by increasing his prescribing of opioids or of morphine type drugs. So again, an unintended consequences of something that seems beneficial and helpful. You've probably heard about the pharmaceutical lawsuits around opioids, and these lawsuits are getting some pharmaceutical companies to close. Others are paying, have paid or will be paying huge sums of money back into the system. And my hope is that money is actually used to improve pain management and to help treat substance use disorder. But honestly, the pharma companies marketed these drugs just like they market all the other drugs. And we have a problem in America with industry influence in medicine. The opioid crisis doesn't highlight the fact that opioid companies are a problem. They really should highlight the fact that all of this industry marketing is a conflict of interest in the healthcare that that we produce. And it's true that some docs really are bad docs out there. We know from good research that it's very rare, but this is actually the case of a physician in LA who had the DEA wire addicts to go into the practice and basically bring in fake records. The doctor would say, I've reviewed the records, and give them a lot of abusable drugs that they want. This is actually an x-ray that this wired fake patient brought in. And some of you may recognize the telltale sign. This is actually the x-ray of a dog. This is one of the x-rays that the doctor cited as supporting the prescribing of opioids for the patient. So there sure are bad actors out there. So how did we get here? Well, I mentioned there's a lack of education. There's an urge to satisfy patients that may be a little harmful. There's pharmaceutical industry influence, and some prescribers are cooks. But there are other influences. One is that when I was training, it was a time when we had just come out of a phase of realizing that cancer patients were undertreated for pain. And when we brought opioids to bear in their care got better. That was a risk worth taking. And the data suggested that it was pretty safe because someone who had pain was unlikely to get addiction. That data was wrong. And we let our guard down and we extrapolated to chronic illnesses. And then it became easy to just give out opioids. So I think we've gotten the messaging right now, but what we haven't rectified is the fact that clinicians still don't have enough time to work with patients in pain. People in pain have complex stories, and the impact on their lives are complex. And often their insurance companies don't pay for the care that they need, which is often rehabilitation, substantial continuity, physical therapy, psychological support, and other kinds of interventions that take a while to work. That's really the enemy of our insurance companies. But this crisis has brought us to a change in our philosophy. This is actually a book that I wrote back in 2007 or 2007, before the opioid crisis was really well known, about being safe with these drugs and balancing risks and benefits. And that's something that we're starting to teach. In our program, we kind of led the way in changing the competencies that are expected for graduates of health professional schools, so that we have goals for addressing the issues of pain care in our doctors, nurses, pharmacists, physical therapists, et cetera. Unfortunately, it's going to take a long time for those clinicians who are coming out of schools now to get to the front line of primary care that you receive when you get healthcare. So we're also doing outreach to primary care clinicians all over California and hopefully soon nationally, to try to change this paradigm in the prescribing of opioids so that we're balancing risks versus benefits. The hard part here is that, unlike having a broken bone where you can do an X-ray and see the bone's broken, it's hard to see the pain. And pain is always a subjective phenomenon. This is actually the definition of pain by the International Association for the Study of Pain. And really, I didn't put it on here for you to read it. I wanted to see this yellow box with the dots because I couldn't actually put all the words on here. This is the leading professional organization for pain in the world. And if this is the best that they can do for pain, imagine how the rest of us clinicians do who are trying to treat it. The bottom line is, as I said, it's subjective. It's essentially an untestable hypothesis. I hear doctors tell me all the time that this person's in pain or that person isn't in pain. And really what that says to me is that the doctor thinks they're in pain or the doctor thinks they're not in pain, but it doesn't have any meaning for the patient itself. pain can have many meanings to different people. It's truly a mind-body phenomenon. So, if you break your arm and you're a 10 out of 10 of pain, and I break my arm and a 6 out of 10 of pain, that doesn't mean the 10 out of 10 is more pain. It's really an interpretation. What patients uniformly feel is that they don't want me to tell them that their pain is all in their head. They don't want to hear that because they don't want to believe that their pain isn't physical when they know it is, and they don't want to be stigmatized by a psychological or mental disease where we'll relegate the care to ignore their physical pain and essentially abandon what they think they need. But this is very important, that you can't prove that anyone does or doesn't have pain. But what we can prove is that someone who complains to us of pain can get better. And better usually means that the things that pain takes away from them in their health and their lives can be restored. So we look at pain in terms of its alarm, and that was the title of this talk. Pain is an alarm that tells us that we're at harm. And when the alarm is on, as many of you may know, when you've had pain, you stop what you're doing. You're not texting, tweeting, knitting, fixing the car, gardening. You stop and you attend to the problem, because architecturally, that is how we're wired. And it's a call that we all take if that signal gets high enough. So pain tells us to stop and slow down. But when the alarm stops us in our tracks too long and doesn't turn off, that's when the symptom of pain becomes the disease of pain. And that's when pain makes you dysfunctional. And it's that dysfunction that we tune into and we can use as the objective marker of pain. So if someone comes to me and says, I have pain, and I ask them the question, what is it that you can't do now that you could do before your pain? If the answer is nothing, I can do everything. I just don't like having pain. I don't disbelieve them, but I won't take life-threatening risk to treat them. If they come in and say, I'm in pain and I can't do anything, and I know some of you know this, some of you know about this, and they say, I can't live like this. They may need surgery, or they may need a much more potent intervention that has risk. One of my favorite sayings is that when someone's in pain, there's no risk-free option, because pain itself does harm. It makes you dysfunctional or decreases your function. It's initially adaptive, but then becomes maladaptive. And when people are in pain, their immune systems drop and they actually become unhealthy. One of the questions that I often get is, what does pain change the body? It does. It has many, many different impacts on the body, and when it lasts too long, these are deleterious effects. So we use function to understand pain. We ask people, what is it that you can do now with the treatment that you couldn't do before with your pain, or vice versa? What did your pain take away? And we look at those objective functions to monitor what we do. It's interesting because when you compare that to addiction, addiction is the compulsive use of a drug, or drug addiction, that is, the compulsive use of a drug that produces dysfunction and the continued use despite that dysfunction or harm. So addiction leads to worsening function. Pain relief and proper analgesia should lead to increased function. This is what we're trying to teach our clinicians and our future clinicians, which will help us use these drugs more safely. So there are many types of pain, and I'm not going to spend a ton of time talking about them, but the three categories that we have are nociceptive pain, neuropathic pain, and idiopathic pain. Nociceptive, which really is the perception of noxious stimulation, is normal pain. It's when your alarm is working and you sense something that's noxious, either something's touching you, something's broken inside, something's wrong. The alarm goes off. It often localizes you to the area where the pain is, but sometimes it doesn't, like a heart attack, because it's part of your internal viscera or part of your is an internal organ. And really, evolution hasn't caught up to the fact that we can treat heart disease, you may feel it in your arm or your neck or other parts of your body. The same with pain from the bowels or other organs. Nociceptive pain turns on when you have a problem, and it turns off, and it stays on at a lower level during healing and then turns off. That's how the alarm should normally work. Neuropathic pain is when the nervous system, the nervous system that subserves pain, has become injured. So this is abnormal pain. This is when the system is going off abnormally, and it actually goes off differently. It has different signaling. So neuropathic pain will often feel like burning lightning bolts. You'll feel, some people will feel like they're getting zapped. And it's very, very, very upsetting and hard to tolerate. And we use a very different class of drugs to treat that kind of pain. Now, idiopathic pain is pain that we really don't understand. I mean this as humor, but there's a saying that idiopathic pain means the patient's an idiot and the doctor's pathetic. Totally meant in humor, but there's truth in that when we don't understand the patient often thinks that we don't know what we're doing. And when we don't understand the pain, clinicians often think that the patient's faking. And that's really unfortunate. And again, we try to teach clinicians that even if you don't understand the pathology of the pain or it doesn't make sense, we can pretty much help everyone get better in relieving the suffering that they're having at one level or another. So, my saying is that we can't cure everyone, but we can make almost everyone better who wants to get better. There are many different forms of pain relief out there. There are conventional medicines that you're all familiar with. They range from anti-inflammatories and over-the-counter Tylenol to much more potent medicines. We have procedures and surgery. Again, patients don't like to hear that we're treating them through psychology, again, because most of them have physical pain and they feel that we're gonna abandon them and leave them with mental illness stigma. But the problem there is that you really can't have pain without a brain or without a mind. So the mind is always involved. So the psychology that we frame for people in pain is not like psychology for mental illness. It's much more like sports psychology, where people in pain really struggle to do their daily, get through their daily lives because they've got a blaring alarm on. And we teach them mechanisms very much like what we would treat an athlete who's is going through grueling activities to be able to perform. And I think a lot of patients embrace it more that way. Our psychologists are really like coaches. The same for physical rehabilitation. Many of our patients are very deconditioned and need rehabilitation. It's really the collateral effect of the pain that has become almost more life-threatening than the pain itself. And this is where we bring coaching to bear. It's not traditional physical therapy because we're not looking to cure a hip or a broken bone, but it's really wellness-oriented fitness that we're getting people back to and teaching them how to make gains where they slowly and progressively so they don't harm themselves. And then we're very much engaged in and supportive of alternative medicines and alternative pathways, and trying to flip the disease model of healthcare into a preventive care wellness model. So with that, as I said, we've got lots of different drugs, weak analgesics, strong analgesics. Strong analgesics would include the opioids. Neuropathic analgesics are medicines that calm down overactive nerves where the nervous system is broken. The nervous system that subserves pain is broken, not unlike the nervous system in the heart being broken in an arrhythmia problem, which many people have, or problems with seizures in the brain where the circuitry of the brain is injured. So those are the same medicines we're using for neuropathic pain, anticonvulsants, antiarrhythmics, local anesthetics, et cetera. And there are many, many other adjuvants that treat the amplifiers of the pain, and we give it by every route you can think of, probably more than you can think of. So here we have the oral route. Transdermal is through the skin. Transmucosal is through the buccal layer of the mouth, inside the mouth. Rectal, nasal, intravenous. Intrathecal and epidural is putting actually the medicines into the spinal fluid. I'll talk more about that. And we put actually these medicines directly into the brain as well. That's what intraventricular means. If any of you have been to our pain center or a pain center, you know that we do a lot of procedures to help treat pain. We would rather treat the pain directly if we can, so that someone's not on medicines for a lifetime. So we'll put medications into the spine, on the nerves, into joints, into muscles. As I mentioned, we'll pump medicines into the spinal fluid. And I also mentioned these spinal cord stimulators that we implant in the spine or on peripheral nerves outside of the spine that basically jam the signals and speak the language of the nervous system. And this is basically a map of the spine. It's kind of a map that is a cheat sheet for us, because we can tell exactly where on this map the nerves go to subserve the pain in the body. And we're mapped pretty consistently as human beings. Without this, we'd be pretty lost. But our maker blessed us with this map, and this allows us to treat different regions of the body. So for instance, we could thread a catheter into the thoracic spine and cover the nerves just in the bottom of the feet, or on the sides of the legs, or in the low back, or higher up in the spine, in the thoracic or cervical spine, et cetera. And this is, kind of a cartoon of a spinal cord stimulator. It has a very small battery that you recharge over the skin, and we've threaded it into the spinal cord, and we've mapped it to the area where a patient would have their pain. The nice thing about this tool is that we can actually trial this, meaning we can try it externally. The patient can tell us where they feel their pain. We actually map it to that area. They can try it for days or a week or so. And if it works, then we take them back and we implant this in the operating room under the skin. And it's a completely implanted device that they recharge at home. Similarly, this is on the right side. This is a pump that we would put under the skin, and we would fill with medications, and probably fill about once every month or so. And the medicine would be pumped directly into the spinal fluid. We do this largely with our cancer patients or terminally ill patients, where their pain is quite severe, and we need to essentially hide the medicine in the spine and in the brain, so that it's not going to the rest of the body, because it would cause side effects, and we can get very, very potent effects this way. I'll tell you, these are for a small minority of our patients, but when we need them, they're really quality of life changing interventions. We're looking at rehabilitative cures. You probably are all aware of stem cell therapies. The area of regenerative medicine is one of the fastest growing in healthcare, and we're on the forefront of that. We've done several trials with stem cells in the spine and in different joints, and other approaches of helping the body regenerate itself. And it spans from helping the body bring healing cells and elicit healing processes at the site of an injury. You probably all remember being young and cutting your skin or bumping yourself and healing very quickly, and then something happens as we get older, and that doesn't happen anymore. So we're trying to find pathways to allow us to heal faster and heal better, and we're seeing success there. The other side is injecting these cells that actually can recreate tissues and reform the tissues that have been either injured or suffer wear and tear over a lifetime. This has enormous promise for us. I can't say we're very far along with this right now, but I think in the coming decades, this is going to essentially put pain management out of business, because we're no longer going to treat the pain and cover it up after it happens. We're just going to regrow the organs that are causing the problem. As I said, pharmacological and interventional treatment isn't the only thing. And in fact, for most people in chronic pain, they need physical and psychological rehabilitation, because they've been physically and psychologically traumatized by the pain. Unfortunately, medical insurance doesn't well cover this even today. And it makes no sense to me, because when we bring these therapies to bear, the science shows that we actually get our best outcomes, and they're not relatively inexpensive relative to the high cost of drugs and all these interventions that I'm telling you about. So, we try to have an approach that allows us to kind of look at this in an integrated way, where, we're looking at the biological, psychological, and social aspects of pain in our patients. In our pain center, we see patients every day who need medical management, who need interventional care, but also patients who need psychosocial care. So we have psychologists and social workers working with them, and we have partners in physical rehabilitation as well. We would sure like to be able to have even greater resources in this area than we have. We're really limited by the finances, and I'm hoping that in the future this grows, because I can't tell you how profound the impact of these kinds of treatments are when patients are able to get it. If you're interested in pain, there was a fantastic interview that was done by Anderson Cooper on 60 Minutes about a year ago with Jon Kabat-Zinn. Jon Kabat-Zinn is someone who writes about something called mindful meditation and mindfulness-based stress reduction. When I was a medical school student at the University of California many, many years ago, a young psychologist came to talk to us about the work he was doing in the basement with patients who nobody else could treat, particularly patients in pain. And that was Jon Kabat-Zinn. He was doing this work through meditation and helping people to essentially harness power that they had over their minds that wasn't new. These are techniques that the Buddhists knew about 5,000 years ago, and his outcomes were truly remarkable. And he's really, since then, I like to say, since he met me, he's grown to create an area of healthcare that was ignored and is now really being embraced, this mindfulness. I joke about him, when he met me, because I'm not sure he even remembers meeting me. But with that, this is worth looking at if you're interested in the work that he does with pain patients. I thought it's about a 10, 12-minute interview that I think is worth looking at. This is the kind of work we're looking at and we do with our patients. We're also doing some virtual reality work. Again, virtual reality is a way to access how the brain reacts to pain and teach people different ways of reacting, and can be very, very powerful and have really therapeutic impacts that we've never been able to access before. It's still in its infancy, but this is an area you're going to hear a lot more about in the future. And then, as I said, we're very interested in looking at alternatives, but I hate to use the word alternatives, because when I think about alternatives, really what I'm thinking about are very conventional things that exist in our lifestyle that we ignore, like what we put in our body, what we do with our body. And just as Jon Kabat-Zinn talks about what we put in our mind and do with our mind. These are very powerful influences on pain, and we're very much looking at these. Unfortunately, it's hard to give them to patients because they're not viewed as worthy of insurance payments, and many patients can't afford it. We started an acupuncture clinic probably 20 years ago. And we have a very growing acupuncture clinic now. Insurance companies are starting to pay for acupuncture, which is great, but it's only one modality that can help get our patients back to function. I showed this slide knowing that I showed it a while ago, and I was criticized for the two people on the right-hand side who are not wearing helmets. Someone stood up and said, "I can't believe you showed that slide. It's so irresponsible. They're not wearing helmets." I want to say they just stopped and they took their helmets off, and they were so happy to have their bike ride that they threw them away, and out of joy and health. But really, wellness is good pain management. So many of my patients have problems that would have been avoidable had they had some guidance in terms of their lifestyle and really balancing the needs that we have in what we put in our bodies, or the food we eat, the air we breathe, what we do with our bodies, the activities that we have, what we put in our minds and what we do with our minds, including our thoughts, our experiences, our social systems. This is a time when it's hard to not think about social justice and how that impacts our wellness states. So, we at UC Davis are right at the, it's a perfect place to be looking at wellness. We're at the foot of Napa Valley. We're at the top of the food basket for America and in the farm to fork capital. And I hope you're going to hear a lot more about UC Davis wellness, because it's something that our center is working on hard to bring together all the resources at UC Davis that could really make our university the world leader in this area. So I was told that I had about 40 minutes and we wanted to leave about 20 minutes for a discussion. So I'm gonna sum up here that, really what we do in pain management is treat suffering. There's a field of hospice and palliative care, which I think is a misnomer in that, hospice brings together all these different services to help people at the end of life. And I like to say that I believe in hospice at birth, because it's the ideal way to take care of people. And palliative care is a term that is often thought, is really guided towards people with severe chronic illnesses and end-of-life care. And again, what we do in pain management is palliative care, except we don't discriminate against people who aren't dying. We look at palliating symptoms as a primary goal of medicine. We cure when we can, but we treat suffering always as a major Hippocratic principle of medicine. But to do it, you've got to be able to understand whole people. And in medicine, we've really partitioned out healthcare. We look at the brain as separate from the shoulders. We look at the heart as separate from the liver. We look at, the breathing system as, as different than our infectious disease problems. But they're all overlapping and interrelated. As I said, you can't have pain really without a body and a mind. And that's what makes a person. So we have to be able to look at them, our patients, as whole people, which requires us to push against the siloing in medicine, and is really the reason why we don't educate our clinicians, because pain is part of every one of the big disciplines within medicine, but it's not the primary part of any. So it's ultimately orphaned when it comes to the teaching committee or the curriculum committee in these schools of medicine, nursing, psychology, pharmacy, etc. So, I'm coming back around to where we started with the opioid crisis, and I want to say that it's much more than about opioids. My worry about the opioid crisis is that all we're going to do with it is try to get people to stop using opioids, which will be a shame, because opioids are a vital tool. They're part of the World Health Organization essential toolkit for clinicians. If you were in severe pain, you might need an opioid, and you'd be glad you'd get it. But just like many serious drugs that have very toxic side effects, We use these drugs all the time in medicine, and we use them safely. So we need to learn how to use opioids. And my hope is that we use this opportunity to see that the opioid crisis was largely driven by the education gap, that we recognize that people need to treat pain, but we never trained our clinicians. And now what we're going to do is, hopefully not, but it seems like what we're doing is training our future clinicians simply to not use opioids, rather than to learn about pain and only use opioids rarely when you need them, when the benefits outweigh the risks. So it'll be interesting to see what happens now as the COVID crisis comes to a close, which has made it seem like we don't have an opioid crisis anymore. But in fact, the opioid crisis has gotten worse, not because of prescriptions, but because of illicit, very, very potent opioids that are coming onto our shores from outside the country. So, you know, again, I said this to you before, we cure sometimes, but we treat often, and we comfort always. That's our motto in medicine, not pain medicine. And this is a quote I want to leave you with from Dr. Ben Rich, who was our first endowed chair of medical ethics at UC Davis, and a close colleague and a part of our division. And he has a quote that I'll never forget, which is, "It shouldn't take an act of courage to treat pain." And my last quote I'll leave you with is, "We can't cure everyone, but we can help almost everyone get better." I said that before. My hope is that there's a silver lining in the opioid crisis, and that what's going to come out of this is better pain care, but we're going to need a lot of attention to the solution to make sure that we get it right. So with that, I'm going to conclude, and I thank you all for giving me the chance to give you my spiel, and I'm happy to entertain any questions. And I'm going to take this off of sharing if I can. Let's see. And I'm going to invite you to turn on your mics. If you do have a question, please feel free to turn on your microphones.
I'm going to go ahead and help out, facilitate this if I can. Thank you, first of all, Dr. Fishman, for that wonderful presentation.
Thank you.
We would love to have people interact with questions. The best way to do that is actually through the question and answer format. I'm not sure everybody has the opportunity to turn their mics on. So we've had a couple come in, and I'd like to start first by asking, the first one that came in is, Dr. Fishman, does chronic pain change the pain receptors in the brain? And if so, is there any way to reverse it?
So that is a great question. And the answer is yes. We know that, pain, it's not a hardwired system. It's a plastic system that's changing moment by moment pain. So for instance, if I were to take a lit cigarette, and burn my skin, and then take a pin and touch my skin, I would feel pain right where I burned my skin. But if I came back an hour later with that same pin, there would be a big circle area around where I burned the skin that would now be hypersensitive to the pain. And that's because the pain system in the spinal cord reacts to the pain that occurred and changes and shifts. It's almost like having a fortress that's being attacked. And when, the first missile or the first cannon fire hits the wall, everyone from the opposite wall comes running to fortify that one wall. So the cells around that area that are represented in the spine actually lower their firing thresholds so that they can fire with less stimuli. So you become hyper-reactive. When that happens chronically, the system actually gets stuck and receptors change, ion channels change. I mean, the biology of it is very, very complicated. But what we do know is that there are dramatic changes that occur. And we've found ways to block some of those changes medically. We know that we block some of those changes electrically with neuromodulation. So it's a very, very interesting area of pursuit. The best way to change it is to take the pain away and let the system resolve. Many people in pain feel like they actually Their problem is that the pain signal keeps turning on. It's actually that the system can't turn itself off. So we have ways of turning it off. And sometimes it comes back with less pain, or actually comes back normal. So it's a tricky system to work with because it's so wired into every part of the human being in all of our functions. But we've made tremendous progress in reversing exactly what this question is getting at. I hope that answers your question.
Great, thank you. We'll wait and see if a couple more questions come in. We did get a question about this being recorded. We are recording this presentation. You will receive, after a couple of days, it takes us a little time to get it to where we can present it to you, but you'll get a copy of this and we would invite you to share it with others. So thank you for that question. Hopefully you'll be able to do that. See if we can wait one more minute for any questions. Maybe while people are typing those, I'll go ahead and just mention, first I want to thank everybody for coming tonight, and mention that the Center for Advancing Pain Relief is really proud to be participating in what's called UC Davis Give Day, which kicks off tomorrow at noon. It's a 29-hour online giving event, and it's an annual event that celebrates UC Davis by encouraging all members of the community to support areas of UC Davis that are important to them. Much of the groundbreaking work that is happening at UC Davis Health and in the Center for Advancing Pain Relief, Dr. Fishman mentioned a few things that are really sort of cutting edge. A lot of those are due to individuals like yourselves that have invested in this work through philanthropic support. So I wanted to mention that tomorrow you'll be receiving a survey that we'd love your feedback on the presentation, and also a link to our online giving page. Since we are participating in Give Day, I wanted to make sure I mentioned that if you found any of this presentation meaningful and were interested in supporting the work of the Center for Advancing Pain Relief, we would encourage you to do that through Give Day, or also I'll have my my contact information up here. We'd love to talk to you about how you might do that. Let's take one more look here. I don't see any other questions. We'd be happy when we share the presentation. I know Dr. Fishman is always willing to share his contact information, so I'll make sure we include that if you have any questions to follow up. Otherwise, Dr. Fishman, if you don't have any other parting thoughts, we will actually end right on time.
Well, thank you all. Appreciate your coming.
Thank you. Everyone have a great night.